Okay, good evening, everyone. It's a good opportunity to meet with you on this virtual stage of academic activity. Hope the audiovisual settings are all set. If any miscommunication occurs, please notify me regarding the voice and the screen. Well, I was thinking of a good subject and material to be the topic of this activity, and I chose this topic. Septic shock basic principles. We have discussed septic shock multiple times before, and we are discussing it again this time. Why is that? Well, because septic shock is one of the most highest causes of mortality worldwide among pediatric age group patients and adults as well. And because identification of the causes, early signs and symptoms, red flags of shock patients can be challenging sometimes. And there is no single specific vital signs that diagnose septic shock. Okay, so let's start discussing the septic shock and take it to the clinical-based scenarios and patient-oriented approach to save our patients earlier. Well, the topic is a bit condensed, but as we have junior residents in the audience, I'll try to make it as simple as possible. Starting with the disclosure of my lecture with the objectives, we will have the definition, the pathophysiology, the types of shock of cold versus warm shock, assessment and identification criteria, management according to the latest guidelines, and if we have some time, we will discuss a case scenario, case discussion-based scenario. Starting with the definition. Well, the sepsis and septic shock definitions has been changing over the decades in different terminologies and description sentences. The latest two definitions are, the last one was in 2016 by the American College of Critical Care Medicine, the ACCM. They define sepsis as, they call it the sepsis 3 consultants. The sepsis, they define it as a life-threatening organ dysfunction caused by a dysregulated host response to infection. And they labeled the septic shock as the subset of sepsis with circulatory and cellular metabolic dysfunction associated with higher rate and risk of mortality. That has been released in February 2016. And we have a new one just released in February 2020 with a surviving sepsis campaign international guidelines for the management of shock and sepsis associated organ dysfunction. They changed the definition as severe infection leading to cardiovascular dysfunction, including hypertension, needs to be treated with vasoactive medication or impaired perfusion. In addition to sepsis-associated organ dysfunction in children as severe infection leading to cardiovascular and or non-cardiovascular organ dysfunction. As I said, it was released in February 2020. Okay, moving to the pathophysiology. We'll talk about basic principles, mainly at cellular level of pathophysiology. Shock results from inadequate oxygen delivery or impaired utilization, leading to tissue hypoxia, cellular dysfunction, and cellular necrosis. Just basic principle of the pathophysiology. Looking to this diagram, hope it's clear. It's the process of to optimize an organ function, we have to have a balance between oxygen delivery and oxygen consumption. Oxygen delivery, sorry, I was trying to use the pointer. Oxygen delivery, main component that provide oxygen delivery is the cardiac output, response, the heart rate and stroke volume, and stroke volume subdivided into preload, afterload, and contractility. Hemoglobin is the main component of optimal oxygen delivery. If there is hemoglobin dysfunction in form of bleeding, hemodilution, or anemia, that would affect oxygen delivery to the tissues, as well as arterial oxygenation and ventilation. Oxygen consumption by the tissues, usually due to metabolic demands. If the patient has fever and anxiety, pain, shivering, muscle activity, etc., that will consume more oxygenation. So the oxygen delivery should be optimized. Otherwise, we will have imbalance. We need all of these factors to control the shock status. It is always about the delicate balance between the supply and demand, and it needs good attention to it, because if a physician might overdo it on the supply side, the worse that might worsen the patient condition as much as the other side of the equation, which is the loss of supply. So it's a very important delicate balance between both oxygen delivery and oxygen consumption to the tissues. Oxygen consumption formula is oxygen delivery multiplied by the oxygen extraction. It might be a bit complicated at your level as program residents, but we'll keep it that way and we'll discuss it further. The oxygen delivery is basically the amount of oxygen delivered to the tissues of the body per minute, and has an equation for that. So if the tissues for any reason got out of this balance, if the balance disturbed, cellular damage occur. Cellular metabolism is no longer able to generate enough energy or power to supply the cells. So the components of cellular homeostasis will be disturbed. Disturbance of cellular homeostasis will result into disturbance of cell membrane ionic pump, accumulation of intracellular sodium with efflux of potassium, accumulation of cytosolic calcium, cell swelling, cell membrane breakdown, cell death, and widespread cellular death will result in multiple organ dysfunction and irreversible damage and subsequent death to cells and organs, and subsequently death. Hypoxia and ischemia, the metabolism disruption occurs from either absolute deficiency of oxygen supply, which will be called hypoxic shock, or a combination of hypoxemia and deficient substrate of delivery of predominantly the glucose. That will be called ischemic shock. And we'll go through the discussion of the importance of the oxygen, the glucose, and all the parameters as we go in the presentation. Most often, patients develop combination of both hypoxic and cellular injury, hypoxic and ischemic injuries. The oxygen delivery is critical either in hypoxic or ischemic injuries as well. Taking the discussion to the basic pathophysiology at cellular level, if shock state develops and cell loss is the balance between the oxygen demand and supply, the 38 ATPs, the main cornerstone of the whole equation. I'm trying to use the pointer, but I don't know how. Just let me fix that. Okay. If the 38 ATP is shifted away and the cell remains with the fraction of the ATPs, subsequently the lactate forms from pyruvate, and anaerobic condition starts causing cellular damage and necrosis. As you can see, the diagram is not complicated, it's just simply easy. When the disruption of ATP generation occurs, that will cause pyruvate to be formed to lactate, and that will cause lactate accumulation. Subsequently, cellular necrosis and cellular death will happen. So inadequate tissue perfusion results in decreased cellular oxygen tension and disruption of normal oxidative hydration with decrease in generation of ATPs, as we said. The microcirculation is generally taken to include the smallest arteries, arterioles, capillaries, and venules. Exchange of gases, nutrients, and metabolites between the blood and tissues occurs almost exclusively at microcirculation level, and adequate perfusion via the microcirculatory network is essential for integrity of tissues and organ function. Okay, that's why when we evaluate a patient with potential septic shock, we depend on a clinical assessment of perfusion and capillary filling time. Keep this in mind. Okay, the sodium potassium ATPs slows, and the cell can no longer maintain membrane polarization integrity, impairing the number of important cellular processes. That's why a patient with septic shock, they will have disturbance in their electrolytes because the anaerobic metabolism occurs and results in production of lactic acid, creating a gap, what's called metabolic acidosis. That's why when a patient with septic shock, we have to check the blood gas and lactate, because they will have hyperlactatemia with metabolic acidosis and should be detected as early as possible. Okay, the first evidence of this dysfunction is a swelling of the endoplasmic reticulum, followed by mitochondrial damage, lysosomal rupture, and entry of interstitial water into the cells, and as the intercellular sodium accumulates. So the loss of extracellular water exacerbates the intravascular volume deficiency. So that's why these patients present to you with intravascular depletion, and they are intravascular depleted and in need of large amount of fluid resuscitation as you go on to restore their intravascular volume and to restore their decent circulation and to ensure good tissue perfusion. And this is the pathophysiological explanation of that. Okay, moving on, the guidelines emphasize on aggressive treatment within the few first hours of presentation and might prevent invariable progression and poor outcomes that characterize the natural clinical course of the shock, manifested clinically by end organ damage, failure with multiple organ dysfunction. Main goal of treatment, please concentrate on this slide, especially juniors. Main goal of treatment when you face a patient with early signs of septic shock is to ensure adequate oxygenation and tissue perfusion, ensuring balance between oxygen consumption and oxygen delivery. And we will go through how you make sure to make this balance. Oxygen delivery depends on integrated function of three systems, mainly lungs by oxygenation, blood by oxygen carrying capacity, and circulatory system to maintain a perfusion. This is a complex formula to maintain adequate tissue delivery, oxygen deliveries to the tissue. Factors to be considered in oxygenation, simple basic physiology, alveolar pulmonary capillary oxygen transport, to ensure the gas exchange in the terminal portion of the lungs, oxygen transport in the blood, which will be carried out by the hemoglobin and oxyhemoglobin, the arterial oxygen content, the oxyhemoglobin dissociation curve, and oxygen delivery. I did not put the graphs as it's a bit complex to you at your level. The third component is the cellular respiration, which is oxygen consumption and oxygen extraction ratio, which will be taken out by the tissue oxygenation depend on microcirculation and the microcirculation adjustment to enhance the oxygen extraction to the tissues itself. Compensatory mechanism to maintain tissue oxygenation. When the patient had a hit of sepsis, his or her body will start to compensate before presenting to the emergency, before clinical signs and symptoms appears. As the oxygen delivery decrease or the oxygen consumption increase, the cardiac output is augmented, receptor stimulation by catecholamines and preloads. The blood flow is redistributed. The body will have the defense mechanism, the compensatory mechanism to redistribute the blood circulation into most important organ systems. The microcirculatory changes enhance the tissue extraction of oxygen. So local adenosine, recruitment of capillary networks, and acidosis will take place on that situation. A key point when a patient presents to you with undifferentiated shock, it is important to, as a clinician, is immediately initiate the therapy with rapidly identifying the etiology so the definitive therapy can be administered to reverse the shock and to prevent multi-organ failure and death as a basic concept. Okay, increased risk of septic shock. Are there patients who has, are there some patients at greater risk of sepsis? Do you think yes or no? What do you think? I'm sorry, I cannot access the chat. I'm trying to access the chat as your answers, to get into your answers. I didn't see it. Okay, anyways, yeah, there are some patients with higher risk to develop septic shock more than others. These patients are the following. Age younger than 1 month. Yeah, it's very known and it's very simply reasonable that younger patient neonates are higher risk to develop sepsis. other than other patients. Patients with serious injuries like major traumas, burn, or penetrating wounds, they have open sources to receive and to develop septic shock and fulminant sepsis more than other patients. Patients with chronic disabilities and medical condition like patients who are like spastic quadriplegic, frequent aspiration pneumonia and sepsis and CP patients, hypotonic patient, bedridden patient, uncorrected congenital hearts, short gut syndrome, and the list is long. Any patient with chronic disabilities or chronic medical condition, they will carry higher risk to develop septic shock, non-classical presentation more than other patients. Other criteria of host immunosuppression, if the patient is immunocompromised due to malignancy, immunosuppressive medication, HIV, severe malnutrition, one of the congenital immunodeficiencies, sickle cell disease, let's say, splenic dysfunction, anything, patient on chemotherapy, any condition that will compromise the immunity, these patients will be at very high risk to develop fulminant sepsis due to infections. Okay, a patient with large surgical incisions, let's say large scars, large laparotomies, poor wound healing, that will facilitate the development of septic shock more than other patients. A patient with indwelling vascular catheters or other invasive devices like patient with a tracheostomy, gastrostomy tube, Foley's catheter, endotracheal tube, whether they have these permanent devices or temporary devices, they will have a higher percentage to catch up the sepsis and to get into septic shock. Patient with urinary tract abnormalities with frequent infections, urogenital anomalies due to a congenital or due to a reason or another, operated, not operated, they carry higher risk to develop septic shock. Okay, moving to the types, we'll just discuss the types of shock, cold versus warm shock. Warm shock, which is called distributive shock, characterized by hyperdynamic or high output physiology and decreased systemic vascular resistance and elevated cardiac output. So these patients will come to you like flushed, Bursky capillary fill, you might class it as normal, and that, but actually they hide into early signs of warm septic shock. The manifestation will be a flash capillary refill less than a second, bounding pulses, warm, dry extremities, wide pulse pressure, typically more than 40 millimeter mercury in older children. So a message to the juniors, when you have a patient and you don't know if this patient is nicely warm due to normal function, or this is early signs of sepsis, please ask for help for reassessment again. And please take the chance to examine every patient regarding the perfusion to develop your skills regarding differentiation between septic patient and warm septic shock from the normal, nice warm of normal patient. Cold shock, it's reflect the increased systemic vascular resistance and the contrast of the warm shock and decreased cardiac output. Patient will have delayed capillary fill more than 2 seconds, diminished pulses and motile or cold extremities. Example for that, let's assume CP patient who has not been fed and was not taken orally for a long time. He has, let's say, infected bed sore and comes to you very dry, delayed capillary fill, cold extremities. Don't interpret these signs as this is environmental factors. Take it seriously. These patients might be in a form of cold shock and they might progress to multi-organ failure and death. Other physiological findings that you might face with both types, toxic or ill appearance. This is very important sign. So the minute the patient enters the emergency, eyeball the patient as a general condition and start to evaluate, is he looking well or ill? Is he toxic? Do I need to transfer my patient to resuscitation room and start aggressive management, or the patient is doing fine, I can just examine him in regular emergency room. A patient might have signs of dehydration and rigors, altered mental status. They will come to you with altered level of consciousness compared to their baseline, because our patient is not always all the time normal patient for age, and their mentality might vary. So you have to have an estimation. Is this patient basically having altered level of consciousness compared to his baseline? And you can ask the parents to help you what is the baseline of the patient, and that will determine at which condition you are and at which level that the patient is truly lethargic or not. Most of the patients would have some activities, baseline activities. Even CP patients, they would have. They will not be in vegetative status unless, you know, a few patients would be. Also decreased tone in neonates and infant, and seizures. Seizures can develop due to either CNS infections, meningitis, meningoencephalitis, or electrolyte disturbance that occur during the septic shock if the patient present late, or due to the severe condition of metabolic acidosis, plus low cerebral blood perfusion, severe hypotension that would cause the manifestation of the seizure. Respiratory depression or failure can occur. Pulmonary release or decreased breath sounds, distended and tender abdomen. You can face that in some patients, basically with the chronic illnesses. Costovertebral and ankle tenderness, macular arrhythmias like toxic shock syndromes, peripheral edema that can be due to capillary leak if the patient presented later. So if you have edematous patient, just analyze what is the cause of this edema. Is it possibly underlying septic shock ongoing and the patient is coming in a late stage? Yes or no, and start from there. Moving to the assessment and identification. How to assess a septic child? Well, child will not come to you saying, I'm septic. The mother will not come to you and saying, doctor, my child is basically in septic shock. So how to assess a septic child? The key point of pediatric sepsis in the emergency department is identification of septic child. The guidelines cornerstone assessment tool was vitals. So age-based vital signs are the first step in assessment. This is what the book said. But I would say general look. If you have a good general look at the patient, good eyeballing to the patient, whole assessment, that might give you a clue from the first minute you face a patient. You face a patient, especially those who comes to the emergency department, regardless of their complaint, because septic shock will not have one complaint. Mother might come to you to the emergency with a vague complaint. She doesn't know what to do, but she feels her child is not himself or herself, and she will just come to you and throw non-relevant complaints. She might say, my child is vomiting or sleeping over, or I feel him hot, or whatever complaint, but that might not reflect the actual condition that the patient is sick. So the moment the child enters in the room, if the child is walking, if the patient is carried by the family, the age of the patient, the weight, the general condition, the thrive, all of this assessment can take your first minute of assessment towards if this patient is sick or not. Is he conscious? Is he looking around? Is he interested in surrounding, interactive with the family? Anything, social anxieties. Is the patient reaction is proper to age and proper to the place he is in? That will give you a clue if the patient is septic or not. Vitals analysis. Tachypnea and tachycardia are early findings, so just keep it in mind. If you have a patient who's tachypneic and tachycardic, you have to spend a time analyzing what is the real cause behind this tachypnea and tachycardia. Is it sepsis? If it is, initiate your therapy. If you are not sure, as a junior level, please ask for help as early as possible. Don't pass it as patient is tachypneic because he's febrile, patient is tachycardic, patient is tachycardic because he's febrile, tachypneic also as he's febrile. No, just analyze it properly, and you will go and you will take the lead for the early assessment of septic shock. If hypertension present, that it's a game over. You know why? Because if true hypertension occurs for the systolic blood pressure or the mean arterial blood pressure is present upon your presentation, the patient presentation, means that the patient is already far down the sepsis path. So the mortality is high and it's doubling at that time. The subsequent crashing of the patient will be catastrophic in a couple of few hours. So warning signs of possible sepsis, including the following: altered level of consciousness. This is a very important sign. I will tell you how to interpret that. Hypothermia or hyperthermia or none. Okay. hypothermia is one of the sepsis signs. Don't neglect that the patient is not febrile, but he is not basically normal temperature, normal body temperature. So hypothermia is significant as hyperthermia. Delayed capillary refill, cool extremities. Some patient would come to you like with fluid loss. The mother would say, my child is having vomiting, diarrhea for a couple of days, not taking oral well. You will consider dehydration, you will start fluids, and after which vitals will be a bit reassuring or borderlines, and you will send your patient to the floor. The next day, the patient will crash down with sepsis and multi-organ failure. Please assess capillary refill very good. Cold extremities is very concerning and interpret very well, please. Don't pass it as like environmental factors. Don't pass it like the patient is in a cold room or exposure and they got this. The only patient who might really not able to maintain their body temperature and can be affected by the room temperature and environmental factors are the neonates. Older than neonates, they should be able to maintain their body temperature normally, and any change in their body temperature or capillary refill that might be indicating of a cooking sepsis. So please be careful. Weak peripheral pulses, it's very concerning sign. So get used to how to auscultate a pulse in a patient. When you have any patient, just touch their pulses, central peripheral, get used to how to assess for pulses. Okay, and decrease urine output. This information mother might not know and might not tell you that my child is not passing urine. So you need to direct her to ask specifically, when was the last meal the patient take, how many hours, and when was the last diaper change. This is very important. Direct this question to the mother because she will not notice. Maybe her child was not feeding for the last, let's say, 12, 16 hours and she wouldn't say. You have to ask directed questions and extract the information that would lead you to how severe your patient is. All of these, if present in a patient, they will indicate poor end organ perfusion, so be careful. If you catch up your patient early, that will be a good catchment. If not, your patient might go into irreversible cascade of sepsis and subsequent multi-organ failure and death. Okay, how to catch the patient early? I would say clinically by general look, and we have spent a few minutes discussing this point. If you don't understand, just let me know. I will repeat it for you. Juniors, please. Activity, interest in surrounding, interaction to parents, level of consciousness. All of this needs a minute from you just to assess. Work of breathing. If the patient is working hard, struggling to breathe, that would reflect that it's something ongoing. Let me give you an example. Let me speak in Arabic. If the patient إذا كان المريض like مشغول بنفسه, he's not interested to look at you, he's just concentrating to breathe, that means something wrong is going on with your patient. If the patient is not interested to fight you or to react his social distance per age, there is something wrong. You need to know. So the patients who will come to you with non-bright look, basically throwing their bodies on the bed, not interested in surrounding, they just close their eyes. Even if they are not sleeping, they are too tired to interact or to argue with the mother or with you as a physician. These patients have something wrong ongoing. Please detect it early. Subsequently, you will assess the perfusion, capillary refill, analyze the vitals, and correlate to complaints, and start head-to-toe examination. Regardless of the complaint, always examine head-to-toe examination. Regardless of the mother just say to you, my patient is having upper respiratory symptoms. Okay, let's assess patient head-to-toe and examine. Every single system will not take more than 5 minutes to examine a patient. Okay, biochemically, VBG, lactate, and glucose, serum lights, coagulation profile. These are main, I would call it main bedside tools to assess sickness of a patient. I would consider VBG, lactate, and glucose as vitals to any patient who has doubtful complaint, who has doubtful sickness status, whatever. VBG, lactate, and glucose are vitals added to your 5 vitals that you will take from the monitor. Okay, if you have a sick looking child with normal labs, how you would interpret that? And if, on the contrary, if you have a well looking child and a bad lab results. Example, I have a child who is basically lethargic, mildly pale, tachypneic and tachycardics, and I did VBG. VBG are perfectly normal, pH 7.40, PCO2 29, let's say 25, bicarb 20, lactate 1.9. Who should I believe, the blood gas or the patient? What do you think? Juniors, what do you think? Anyone can participate in the discussion? Okay, some of you would say the patient. Anyone would believe the numbers of the vitals and the pathways, okay? We don't depend on individual subjective assessment. We have to have objective measurement and objective measures to assess a patient. But listen to this. If you have a sick-looking child with a normal labs, believe the patient. And if you have a well-looking child with a bad results of the blood gas or whatever the lab result, believe the bad thing. Always take the worst and go from there, because the patient might be compensated. That's why he's well looking, but the lab results start to decline, and the vice versa. If the patient is sick looking and the labs are still perfectly normal, does not match the patient, that will tell you there is ongoing sepsis that has not been appeared yet in the labs, but the patient exhibiting that in their clinical presentation. So always assess and believe the worst. Assess, reassess, analyze, use critical thinking to fit your patient under possible diagnosis and anticipate how your patient will progress. So if you have a sick looking patient and you have a perfect gas, a perfect like normal sugar, normal lactate and normal CBC or benign CBC, benign electrolytes, don't send the patient home. Keep him under your monitoring, reassess, repeat the labs. After 2 hours from repeating the first set of labs, you will see the whole numbers will change. Patient will be coagulopathic, acidotic, hypoglycemic, hyperglycemic. The whole picture will change. This is what we see in real life and anticipate and facing a patient. The first set of lab will be perfectly normal. 2 hours from that, everything would crash down and the patient clinically will crash down and the labs will change. So trust your gut, trust your feeling in assessment, and objectivize your assessment with good objective materials. Combination of both assessment and reassessment analysis will be your tool to take your patient to which area that needs to be. You will admit your patient to regular floor, you will take it to high dependency unit, you will resuscitate your patient in the emergency room, or you will take patient to the intensive care unit. To which level you need to be aggressive, to which level you need to reassure appearance, or just anticipate that you lose your patient, so you need to be one step ahead of your patient. We always say just be one step ahead of your patient. At the junior level, you need to be 5 steps ahead of your patient, because you don't know how the patient would react. Pediatrics are basically very fragile and vulnerable and sometimes unpredictable. So you have to be broad-minded, assess and reassess again, analyze, and put a long list of differential diagnoses to fit your patient in. And one bit of advice from my side: if you assess a patient, just ask yourself one question. Is my patient potentially septic or not? If you answer the question with full confidence that your patient is out of sepsis criteria, just be ahead, just be relaxed and go ahead, do whatever you want to do with the patient. But if there is still a questionable or answer regarding the potentially septic, yes or no, don't hesitate to ask for a help from your superior regarding seniors, specialist consultant, whoever, to help you reassessing the patient again. And spend time with the patient to analyze and to know how these patients act and react, and from there act accordingly. Okay, especially the juniors, don't be in a rush that I will leave the patient, I will go to the next patient. Focus on one patient, do the whole analysis again and again, and get the whole picture of the patient. If this patient is in a good condition, that I need to leave him and discharge him home, or I need to no, I need to wait and monitor and all of that. Okay, moving to the management. Management, basically I will conduct it to you as a guideline, and we'll take a quick review to the Survival Sepsis Campaign 2020 guidelines that has been released, and the executive summary that was released in February 2020. Okay. The golden material to manage septic shock is rapid recognition. The goal of initial phase of management for children with septic shock is to rapidly recognize those with infections who have severe sepsis or at risk to rapid progression and septic shock, as we discussed, as well as those at risk of septic shock. Example, if you are the junior covering the emergency and you have a patient coming to you, the mother is saying, well, my child is following in the nephrology clinic and we missed our appointment. We just want you to check up on my child because I feel him febrile. Take it seriously. Because those type of patients would carry high risk of infection, hidden infection, non-classical presentation. They will not come to you like febrile or toxic or sick. They might be like compensating because their body has been through a lot of struggles and a lot of hits of sepsis. So their compensatory mechanism is regulated with each time. So they might not tell you, or they might not present at that point in sepsis, classical sepsis picture. Just give me a minute, just 1 minute. Sorry for the disconnection. Do you hear me now? Okay. Clear so far? We can move on. Okay. So septic shock is associated with high morbidity and mortality, and this sentence has been said over and over again, but keep it in mind because delayed recognition of septic shock has repeatedly been associated with worse clinical outcomes and in adults and pediatrics. Because when you fail to recognize, identify the alarming signs, red flags of a septic patient, when your management is delayed for a reason or another, for system failure, for whatever the reason is, your patient will die in the next couple of hours due to septic shock. And by then, you need to tell the parents that you lost your dearest child and to convey your condolences for their loss. So which one is easier, to take care of a septic patient and do your best and all the evidence-based medical treatment and therapy to save your patient and hammer him with high guns of all medical therapy, or you have to convey condolences to parents who has unfortunate child who has been lost, or delayed management was not, he did not receive in that time. So basically keep this in mind when you evaluate a patient with potential septicemia. Don't say my patient's having septic shock, I started antibiotic, blah, 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 and you leave the room. No. When you have a septic patient, just stay beside the patient till final stabilization step of the please. Okay. Initial resuscitation goals, goals that the goals of care are based on improvement of perfusion, including normal capillary refilling time, and this is very important. That's why I'm telling you, we're discussing basically a theory here. We need to conduct a live bedside session to the junior residents, how to evaluate a patient, how to evaluate a capillary refilling time, the technique of that. Normal peripheral pulses or extremities is the most important thing that you would depend on an initial assessment of a patient who is potentially septic. Improvement of urine output to more than 1 ml per kg per hour, implementation and the resolution of tachycardia and hypotension, basically hemodynamic stability. Okay, going to the point of implementation on mental status. Some patients would crash down and they would need securing their airway with either elective intubation or emergency intubation. So this point will be minus from that because patient will be intubated and sedated. These measures should be continually reassessed to ensure the effectiveness of intervention and for further directed therapy. So when you have a patient and you did your first therapy, let's say you gave a bolus of chlormethylene to your patient, assess and reassess again. Assess the need of a second bolus and assess the effect of the bolus that you gave already. So assessment, reassessment of whatever you did and whatever needed again to be provided or escalated therapy, whether fluids, whether inotropes, respiratory support, antibiotic, and etc. Okay. And the first hour of resuscitation, the goals are to restore and to maintain the airway, oxygenation and ventilation, circulation, and threshold heart rate. Basically ABCs. You have to have secured airway. You have to secure the ABCs of pulse guidelines. This is basically what you need, and we'll go through each point of that. A threshold heart rate. What does that mean? Heart rate that is needed for a patient to maintain a good, decent circulation. بمعنى, don't leave your patient tachycardic to the extreme. They get exhausted after all, and they get into cardiac arrhythmias because tachycardia is worse, as bad as bradycardia. So when you resuscitate your patient and patient has persistent tachycardia, please troubleshoot that. Why is the patient tachycardic? Is he in need of further fluids? Is he in need of further escalation of inotropic support, vasoactive agents? Is he awake on a tube, so needs sedation? Please troubleshoot the tachycardia and optimize it to a threshold age-based acceptable heart rate. Okay, so here we go. We received the patient. We recognize there is septic shock ongoing. So we identify there is a septic shock. So what should we do? This approach is to emphasize the following action. Obtain a vascular access, IV or IO, within 5 minutes. So please, juniors, screenshot this slide and concentrate with me. A vascular access should be obtained within 5 minutes. If it failed, insert an IO. Don't be afraid of inserting an IO. Get your skills, train yourself to insert an IO, because when you need it and a patient needs it and patient life in between your hands, you need to do that thing, no matter how bad or how aggressive it is. Start appropriate fluid resuscitation within 30 minutes. Delay of fluid resuscitation to a patient who is identified. We are talking about, we identified خلاص and the patient is on a sepsis. Delay of fluid resuscitation will carry out higher mortalities. Broad spectrum antibiotic should be given within 60 minutes, within 60 minutes of time of recognition or the time of arrivals. So any delay after that will double the mortalities, or will carry out the mortalities to higher level. For a patient with fluid refractory shock, initiate inotropic support within 60 minutes. Okay. We'll go to the guidelines and I will tell you the differences in between this, but this is what we depend on. Within the first 5 minutes, within the 0 time, you will identify. Within the first 5 minutes, line should be inserted, peripheral line, 2 peripheral lines, large cannulas, 1 for extraction, 1 for resuscitation. Fluid resuscitation should be started within the first 30 minutes. That does not mean you have 30 minutes to wait. To start immediately. Technique is fast push to restore a decent intravascular volume and circulation, and hammer your patient with broad spectrum antibiotics, and we'll talk about that point. Inotrope should be prepared from your second bolus of saline. This is my personally from the practice. If you give a patient a first bolus of 20 cc per kg and he's in need of second bolus, initiate your second bolus. On that time, prepare your inotropes. As long as they are prepared by the nurse, the third bolus should be ongoing. So after the third bolus, you will start your antibiotic, but the preparation and asking for it after the first bolus, after the third bolus finish and you ask for the second, please ask for inotrope support preparation on that time. Just to buy some time that this preparation will take a further time. So be ready with your guns to hit faster when the patient is not responsive to the first bolus, neither the second bolus. Okay, clear? Okay, starting the management with the circulation. We said ABC is our approach, but I will start with the circulation first, then we'll go to the airway and I will tell you why. Starting with the circulation first, first circulation rescue is fluids. Rapid fluid resuscitation, relatively intravascular hypovolemia is a common in septic shock due to vasodilation and capillary leak, and we spoke about the mechanism of that. The major goal of the initial treatment of septic shock consists of rapid fluid resuscitation to restore a tissue perfusion based upon clinical therapeutic endpoints, and we'll speak about that in a minute. Okay, what are the therapeutic endpoints? Anyone knows therapeutic endpoints of fluids resuscitation? Anyone? You can use your mics to answer the question. Quality of pulses. What does quality of pulses mean? That the pulses are well felt, and they are optimally felt, not brisk, not bounding, normal quality of pulses that you can feel, central peripheral and normal quality, not delayed capillary fill, not bounding pulses, like normal optimal pulses and optimal capillary filling time. So improvement quality of pulses, capillary filling time, mental status, and we discussed if the patient is intubated, sedated, that will be minus. Urine output, the target is 1 ml per kg per hour. The lactate, trend of lactate should be normalizing or declining. Otherwise, if it's not declining, if it's climbing up, your patient is your cycle of septic shock is not reversed, your treatment is not effective yet, the patient is not responding yet. So troubleshoot what is going on. The patient needs more fluid, more introbes, further escalation of therapy. There is something you did not troubleshoot. There is something still hidden. There is something, there is some tissue perfusion dysfunction at one level that you did not treat yet. So lactate is very sensitive parameter to your therapeutic, as a therapeutic endpoint and effectiveness of management. And central venous oxygen saturation, this is a very golden parameter that we need to depend on. The only problem that this needs to be extracted from central line, neckline IJs to be extracted, and in our condition, central lines might not be available in the first hour of presentation at the patient in the emergency. So the fluid used is normal saline, 0.9 saline. The recommendation is 20 ml per kg. The surviving sepsis campaign previous recommendation was up to 30 ml per kg per bolus. The bolus guideline is 20 ml per kg over 5 to 20 minutes. I would say as fast as possible, infusion with a manual push to be given to restore a decent circulation, and can be repeated up to 60 ml per kg during the first hour. So at the first hour pass and your patient needed 60 ml per kg fluid, I would assume the patient is already in introbes. Okay. After the initial infusion, the child should be quickly reassessed for signs of inadequate organ perfusion, and determine if the additional fluid is needed, and to identify if any signs of fluid overload. As a tip of advice, before giving any bolus of fluid, assess regarding perfusion, cardiovascular auscultation, and chest auscultation. Before giving the bolus and after each bolus, examine again and have it as a manner that you would do it quickly without delay. Because if you would give the first bolus of normal saline and the patient is needing of a second bolus, before you give that bolus, take a minute just to auscultate the heart, the chest for pulmonary rallies and gallop. Honestly, it's not that it's not observed unless in a patient with cardiac patient, and you missed that the patient is cardiac from the first place and you started to give large amount of fluids. But cardiac patient should be assessed from the beginning that the patient is in cardiogenic shocks or with the possible cardiomyopathy, and the fluid resuscitation should be different. That should be restricted to 5 ml per kg over a longer period of 30 minutes rather than fast push as in septic. We are talking about septic patient. They are truly, if they are truly septic, they are truly intravascularly depleted. So no matter how fluid you give them, you will not reach at that point because they would need that amount of fluid if we go objectively and give up to 60 or 80 ml per kg. But as your level, reassess a patient regarding the perfusion, capillary filling time, pulses, cardiac auscultation, chest auscultation, and abdominal exam for hepatomegaly before and after each bolus, till you develop your own skills of assessment and confidence of giving fluid, because fluid is dangerous as well. It's a dangerous medication. It's a life-saving and a killer at the same time if used in a wrong way. Key point, ideally within the first hour of treatment, the physician should determine if the patient is responding to the timely fluid administration or not. So you would say, my patient would need a second bolus or not. How you would say that? Clinically, by the clinical assessment, as we said, and biochemically with the parameters of lactate. You would ask me, I should repeat the gas after the first bolus? No. Assessment should be clinical, and you will go from there. The first gas will determine how aggressive you will go with the fluid. Let's say you have a patient with pH of 6.9, bicarb of 8, and lactate of 20 on 10, let's say 10, and the patient is potentially septic, nothing else. We're not talking about any other etiology of this bad blood gas, only septic. You will go as much as you can with the fluid to restore a decent circulation and to come down with that lactate, with the fluid, with the antibiotics, with the inotropes. And you will repeat the gas as soon as possible in a couple of hours, in 1 hour, in 2 hours, to see the trend of that lactate. If you resuscitate your patient well, the acidosis and the lactate trend should be coming down, let's say from 10 down to 7, 6, and you will go from there. That will give you a relief that you start to concise that sepsis cycle and to contain it. If that trend of lactate worsen, that means something is wrong. Something is really wrong, and you did not catch what's going on, and you need to redo the calculation again. Okay. So patients who are fluid refractory, that is not responding to the fluid, should begin inotropic support and tailored to the blood pressure, whether cold or warm shock is present. What does tailored mean? Means goal-directed and specified to that type of patient and that type of shock, the choice of inotropes. Okay, increase attention to rapid recognition, aggressive fluid management. Again, I'm saying it's in the book, it's in the guidelines. It should be aggressive fluid management and aggressive treatment. Otherwise, you will lose the patient. And early administration of vasoactive agent and antibiotic has been associated with significant decrease in the mortality from severe sepsis and septic shock. On the other hand, the delay will cause higher mortality, as we said before. So establishing ongoing monitoring of tissue perfusion. Once effective circulation volume has been restored, ongoing fluid requirements are guided by monitoring of tissue perfusion. As we said, we are giving fluid, let's assess the result of the fluid I gave and the need of the further fluid. And should be with each bolus you give, okay? Again, I'm putting the therapeutic endpoint. Please screenshot this slide, keep it in mind. Always keep it in mind and review it each time you have a sick patient or septic patient. Okay, second line of circulation optimization is vasoactive agent. If no sign of improvement within 30 minutes to 1 hour of aggressive fluid resuscitation means that you exceed the 60 ml per kg, the initiation of inotropic should be indicated. At the same time, we are talking here purely about the septic shock patient. We're not talking about different type of shocks, because different type of shock, let's say cardiogenic shock, your first priority is the vasoactive agents of inotrope that improve the contractility rather than fluid. So we are talking here about septic shock. Don't confuse it with other type of shock, okay? Consider which agent you will use early during the second bolus of normal saline, as I said, so it can be ready by administration at 60-minute mark without delay if necessary. Okay, so the vasoactive agent for a cold shock, you would use epinephrine. The dose is 0.05 to 0.3 mic per kg per minute. This is your first initial dose to start with, and you will titrate it up to 1. Warm shock, you will use norepinephrine, the same, you will titrate it up to 1. If you have a crashing down patient, a resting patient, you would cold patient, you will start epi, subsequently norepi will follow, dopamine and dobutamine will follow, and you will start hydrocortisone on the first as soon as possible. So we are talking about the classification of shock, but if there is no response to one agent, one inotrope, you will follow with the subsequent inotropes. We have only 4 inotropes that is known. We spoke about vasopressin one time before, and I don't want to go the direction to that agent. Let's focus on epi, dopamine, and dobutamine. The initial dose as written, preparation should be calculated, and dilution should be double checked, please. Pumping, the pump machine itself, it should be caliber to the dose chosen, and this is how you go with the patient with with shock. Once you have a patient who's cold, let's say a cold patient, and you decided to start epinephrine, and you started with 0.05 and you escalated to reaching 0.3, 0.3 mic per kg per minute, prepare your norepinephrine and add it. Don't wait till you maximize one inotrope to 1, then you add the next. Once you reach 0.3, this is a high infusion rate, so you need to prepare your second inotrope, and so on and so forth. Okay, clear? Keep in mind that you can safely start those inotropic support through the peripheral IV line, even if the IO, if you have no IV line, you can start it through the IO safely. In the meanwhile, while you're starting it, central line preparation should be asked, and central line should be inserted as soon as possible. But don't delay the initiation of inotrope till after the central line or till after the peripheral line. You can use it IO, IV, or central line. Additional management principle in fluid and vasopressor refractory shock: consider empirical hydrocortisone, as we say, to treat potential relative adrenal insufficiency with a stress dose hydrocort. Furthermore, involvement of the pediatric intensive care unit and the critical care unit for initiation of second line of therapies as refractory shocks of ECMOs. The service is not available in our hospital institutions, but this is basically the guidelines. If the medical therapy fails, we should go to the next level of extracorporeal membrane oxygenation rescue maneuvers. Back to the airway. We finished the circulation. Now we will move to the airway. Why I start with the circulation first? It's not ABCs. We started the circulation first. Here, the answer will come in a minute. When to intubate a patient who is developing sepsis and septic shock? Consider early intubation in fluid refractory shock after 3 boluses of normal saline, 20 cc per kg each, or any compromised airway, severe lethargy, or encephalopathy. Let's give a scenario and take it from there. You have a patient who is severely dehydrated coming to you with crashing down vitals and acidotic blood pressure. Start your fluids and intubate immediately. Okay, if a patient is conscious, level of consciousness is lethargic, but otherwise his GCS is maintained, and the fluid reached more than 3 boluses, and you start one inotrope reaching 0.3 mic per kg per minute, and you're adding the second inotrope, go ahead and prepare your intubation and intubate. And the indication for intubation at that point will be hemodynamic instability. Okay, we discussed this point over and over again, that don't delay the intubation when your hemodynamic is not achieved. Okay, as we said, the cardiac output is the equation of heart rate and stroke volume. To augment the cardiac output, you need to take the just lighten the burden on the heart by ventilating your patient and to optimize the cardiac output to the vital organs at that point. So the indication for intubating a septic patient is not lethargy, is not encephalopathy, is not airway compromise, it's hemodynamic instability. This is a strong indication to intubate such patients. Okay. Infants or neonates with severe sepsis might require early intubation. As I said, as long as your patient is small in age, small weight, small body surface area, they crash very fast. So earlier intubation should be considered with those patients. Let's say a patient who is 4 months old coming to you with sepsis-like picture, high grade temperature, and borderline blood pressure, high lactate, metabolic acidosis. Consider early intubation of these patients as soon as possible because they would need it. They would need the benefit of the intubation and ventilation at that point. Intubation, keep in mind, juniors might not know this point and might not be considered that intubation and mechanical ventilation increases the intrathoracic pressure, which reduces the venous return and leads to worsening shock. The thing is, if your patient is having, let's say, borderline blood pressure or normal blood pressure for age, and you are intubating your patient as elective or or as emergency, the blood pressure will worsen once you start your positive pressure ventilation. So optimize your hemodynamics further before and during the intubation. Therefore, fluid resuscitation must be done first. This is what we said earlier. When you get a shocky patient on the emergency, let's say, start with your fluid while you are preparing your intubation. The priority should be for the circulation first, and the airway second. Or let's say it is simultaneous work as a teamwork of resuscitation, but keep in mind that the hemodynamic will worsen during the intubation and the positive pressure ventilation, so optimize it further before attempting to put a tube down the throat of that patient. Clear? Okay, what is the method to be used in a patient with septic shock? It's RSI, rapid sequence intubation. We'll not discuss this point because this is beyond the scope of this topic. We're just, we can review it some other times, but always use RSI as your intubation method in a septic patient. Okay, antibiotics. We finished with the circulation, we finished with the airway already. Moving to the antibiotics. Empirical antibiotic therapy is prompt identification and treatment of the site of infection. When you have the patient and you start assessing and you examine head to toe, just have an idea of what could be the source of infection. Is it chest infection? Is it gut infection? What is the obvious signs of sepsis in that patient? Usually bacteremia or septicemia will not be detected on that first hour, but clinically, but theoretically speaking, start to direct which part of the body is the cause of the infection and sepsis at that time, and direct your empirical antibiotic therapy accordingly. The timing, whenever possible, broad spectrum IV antibiotic therapy should be begin within the first hour of presentation. So you receive the patient, you inserted the lines, you draw the labs, you give the fluids, you started the inotropes, you put the tube. Antibiotics should be immediately after that. Don't delay it further. So ask for it from the first minute you receive the patient, because as it comes from the pharmacy and prepared, even if in all situations, even in advanced hospital, the delay might be due to systemic failures of the importance, and we don't have stocks of antibiotics in the emergency room or the resuscitation room or in the ICUs. The antibiotics is always stored in the pharmacy. It needs a way to get it. So minutes will pass very fast, and you never know. So take in consideration that antibiotics might be delayed, not due to your delay, might be delayed in the process of releasing it and from the pharmacy. So please ask for it, assign someone to get it personally from the pharmacy as soon as possible, and start giving the antibiotic in the first golden hour of presentation or identification of septic shock. Okay, the rationale for 1 hour target antimicrobial administration comes from observational studies that how poor outcomes would a delay antibiotic therapy even beyond 1 hour. And we will discuss this point regarding the latest guideline of the survival sepsis campaign regarding 1 hour timing and 3 hour timing. I will come to that in a minute. There is studies in PEDS, pediatric series, that each hour delay in antibiotic administration has been associated with an increase in mortality up to 8%. Each hour will increase the mortality by 8%. So do the calculation, do the math that how bad your patient might be, in which condition, and how high the mortality will be if you delay the antibiotic an hour, 2 hours, 3 hours, and so on. So the choice of antibiotic, what antibiotic you should use, it depends on the child age, neonates, older pediatrics age group, but depending on the history, the comorbidities, the clinical syndromes, the possibility of the organism that is be responsible, and consult the experts ID pediatric infectious diseases when needed. But generally speaking, you need to cover gram-negative plus or minus gram-positives. If there is a patient with, let's say, instruments inserted with the devices, and if the patient is immunocompromised, if the patient is in critically sick condition, so you need gram-negative coverage, gram-positive coverage, plus or minus antiviral if needed at what you are treating in corona season, let's say. Antifungal coverage, do you need that or not? Depends on the condition of the patient. But simply, let's say we are most of our patients are community-based cases and community-based service hospital, but we are receiving every now and then a patient who has been treated in tertiary care center, a immunocompromised patient. So analyze the patient comorbidities and choose the antibiotic properly accordingly. But as the antibiotic is your golden saver at that time, we don't want to increase the risk of resistance to the antibiotic, but use it wisely. You need gram-negative coverage, gram-positive coverage at least, and ask yourself, do I need to supply my patient with antiviral? Subsequent, let's say, aminoglycoside, is it needed at that point? Atypical organisms should be covered, yes or no? Antifungal and antiviral. Ask yourself and go from there. Simply speaking, you need ceftriaxone or broad spectrum gram-negative coverage of ceftriaxone, cefotaxime, septic dose or meningic dose accordingly. Vancomycin or cloxacillin as a gram-positive coverage accordingly, and you go, as I said, aminoglycoside if needed. If your patient is oncology patient coming to you in a sick condition, escalate your antibiotic accordingly, and so on and so forth. Okay, moving to labs. What blood work we would draw from a patient who is having septic shock? Starting with rapid blood glucose, glucocheck. Hypoglycemia might accompany metabolic demands, and decrease oral intake for the patient who is developing sepsis or stress hyperglycememia. Both are expected, and both should be managed accordingly. Optimal blood pressure and tight sugar control is very important in a critically sick patient. We don't want our patient to be hyperglycemic or hypoglycemic. Both of them, the effect of both hyper and hypoglycemia is really worsening the condition of the patient. So our target range of blood sugar is 100 to 120 milligram per deciliter. The guidelines, the number varies from between 70 to 150 milligram per deciliter, but usually as a critical care, we aim a sugar between 100 and 120 milligram per deciliter. Arterial blood gas or venous blood gas to ensure inadequate tissue perfusion with lactic acidosis should be troubleshooted and managed accordingly. Hypoxemias as well, secondary to ventilation mismatches and the sepsis of the patient. Blood lactate, elevation of lactate more than 2 millimole per liter suggests hypoperfusion, so take the number seriously, and the serial monitoring of lactate is necessary in such patients. Studies saying if the initial blood lactate is more than 3.5 millimole per liter in a septic patient, that would be associated with increased mortality. So when you have a patient with lactate, let's say 5 or 7, don't leave the patient till you take that number down with your aggressive management. Otherwise, you will lose the patient. So lactate is a very good indicator. Don't interpret that it was difficult extraction due to extraction maneuver. It was not good. Sample was delayed. Blah blah blah. Take the number as and correlate to the patient condition and treat it as aggressive as possible, because once you have a lactate of 3.5 and above, your patient further deterioration is highly anticipated, and you know your night will not be quiet with that patient. Either you save the patient or you'll say goodbye to the patient. Okay, and children with suspected infection of lactate more than 4, the mortality, the odds of mortality at 30 days of presentation and ICU will be more than 3-fold higher than the other patients. So take it seriously. Any number of lactate more than 3.5, please don't ignore that number. Aggressively treat it, monitor it closely, troubleshoot what's going on with the patient, and ensure that your patient is truly receiving the proper management that is needed on timely manner. Keep in mind that we are speaking about hyperlactatemia secondary to septicemia. We're not talking about other causes of hyperlactatemia, okay? Clear so far? Moving to complete blood count, CBC, leukocytosis, leukopenia is basically an important parameter that you know, you need to know at presentation. Serum electrolytes, the patient would have electrolyte disturbance in form of hyponatremia, hyperkalemia, or hypokalemia and hypophosphatemia, and all of that will contribute to either arrhythmias and subsequent complications, and patient might develop the SIDH or other metabolic disorders secondary to fulminant septicemias as well. Blood urea nitrogen and serum creatinine. Elevation in blood urea nitrogen indicate dehydration and creatinine reflecting the prerenal azothemias, and AKI is well-known complication of sepsis, and kidneys are the one of the first organ to shut down after a strong hit of sepsis. So if the patient is experiencing ongoing septicemia and the blood supply, the oxygen demand is not met, so the kidneys will go into acute kidney injury, subsequently renal failure and renal shutdown. And that process is a true complication and non-complication of septic shock. Serum calcium as well, hypocalcemia is well known, so you need to optimize your calcium level up to 1.1 millimole per liter, as we're talking about ionized calcium. Total bilirubin and alanine aminotransferases also needs to be obtained and interpreted as well. Coagulation profile, PT and PTT as it's the indicators for development of DIC. So your patient, if the patient is in septic shock and in DIC, your coagulation profile should be obtained from the first extraction and to be corrected accordingly. Don't leave your patient in the IC picture. Please correct the coagulation accordingly, and this is part of your sepsis management. Fibrinogen and the dimer will be disturbed as decreased in fibrinogen and increased D-dimer support the presence of consumption, coagulopathy, and DIC. Hypofibrogenemia might also be a marker of secondary HLH that you might face, and macrophage activation syndrome in children with sepsis. So the fulminant picture of cytokines released might mimic the picture of HLH or mass in a patient with fulminant septicemia, and fibrinogen D-dimer might give you a clue to which direction the patient might go and prognosticate your patient. Inflammatory biomarkers are C-reactive proteins, and procalcitonin is not strongly recommended in the acute phase, but it's a helper of detecting infections. Furthermore, labs is blood culture, urine analysis, cultures, other cultures that you will need to obtain after stabilization of your patient, like CSF, wound culture, fluid aspiration, abscess drainage, blah, 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 what you need to troubleshoot according to the site of infection. Diagnostic serological testing for virology studies and viral cultures that need to be withdrawn. So, after all of this discussion, we'll just summarize recap the discussion. The summary and key points: early recognition of pediatric sepsis is crucial, and reducing the mortality and morbidity. Hypertension is a light sign. Please don't depend on the number of blood pressure at any time. Depend on clinical evaluation of the patient rather than the numbers. The initial goal of therapy in the first hour is to establish vascular access, we said, in 5 minutes time, provide oxygen supplementation, airway securing accordingly, push isotonic crystalloid fluid boluses, correct hypoglycemia and hypocalcemia, provide broad spectrum antibiotics according to the patient condition and the choice of antibiotic, initiate anaerobic therapy as indicated, consider additional etiology of shock and adrenal insufficiency, and troubleshoot accordingly. Clear so far? واضح? Is it clear? Hello? Okay. So the red flags that that is really should be considered in the red flag that needs to be considered as recognition of pediatric sepsis is the age and weight. As long as your patient weight and age is smaller, just take a higher measurement of higher index of suspicion and be more thorough during evaluation and examination. Unexplained tachycardia after correction of fever and dehydration should be reinterpreted again. It might be a hidden sign of septicemia. Clinical signs of poor perfusion, mental status changes, lethargy, irritability, and tachypnea should be taken seriously in such patients. Those patients might not come to you like, let's say, let's give a scenario of a sickle cell disease patient who is like 9 or 10 years old, old, has been febrile for a while, has been on a single antibiotic, and now level of consciousness is not as usual with lethargy, pain, irritability. Interpret these signs because these patients might be complicated and might be confusing picture. So your interpretation will say that he is lethargic because of the pain, sinus crisis, new sepsis. This is very complex picture to analyze, so take it seriously and put the first thing first, and the killers. The one that will kill your patient is the sepsis. So troubleshoot and ensure that your patient is not developing a new sepsis or progression to the previous sepsis he is on, and act accordingly. Obtain a lab of blood gas, lactate, glucose, new CBC, new electrolyte set. Analyze that patient, examine your patient thoroughly, just see if there is a new hidden infection has not been discovered earlier, and go from there. Don't leave your patient and justify the change of the general condition and the change of the vitals to the previous problem list that the patient has, and pass it as, okay, the patient is already covered with antibiotic, what should I do? No, reassess your patient again. Take a set of lab, examine head to toe, reanalyze what's going on, and assess and reassess again. If you are at junior level, please ask for help to troubleshoot what's wrong with your patient, because these patients are really dynamic and they can change from stable condition to critically sick condition in no time, and we might lose a lot of patients due to late detection and identification of ongoing septicemias. Clear? اوكي again we're saying hypertension is a late sign. Please ما ابغى احد يعتمد على blood pressure as indication of sepsis. If your patient is hypertensive, means the risk and odds of mortality is very high, and this is not identification. If the patient is hypertensive, you did not identify the septic shock, it declared itself. It says I am septic shock. When you identify, means you did not reach the point of hypertension. Another point to be mentioned, worth to be mentioned, especially to the residents covering the intensive care unit, if the numbers of blood pressure is optimal for age, don't depend on that number. Please depend on the trend of vitals, the trend of the blood pressure. If your patient is 2 months old and blood pressure, let's say 2 years old, and the blood pressure is 100, and then came down to 80s. 80s should be okay with the 2 years old, but it is declining from the baseline. So please, the trend of vitals is your key corner analysis of a patient, and act accordingly. So always start your resuscitation with the ABCs, and circulation should be the first priority to you. It's basically a teamwork, and should be done simultaneously at the same time. Early goal-directed therapy, or as early antibiotics should be provided within the first 60 minutes of presentation and identification. Okay, we'll move just to the executive summary by the Survival Sepsis Campaign that has been released in February 2020. It's almost the accumulation of what we have been said. I can just discuss with you the PDF file. I can send it to you, and we discuss it and read it some other time. I just highlighted the points that they have been discussing, and they put this summary has been discussing the strength of evidence, the quality of evidence of the previous guidelines suggestions. So I just highlighted the important points, that the screening, diagnosis, and systemic management of sepsis should be your first priority, and they put the antimicrobial therapy within the first hour, and the source control of sepsis as sorry, that page was the second page. This is the first page. Fluid therapy, as we said, 40 to 60 ml per kg boluses divided into 3 boluses within the first hour time. Titrate to clinical markers of cardiac output, and discontinue fluid overload signs developed. They call it as weak recommendation, but we are following it strongly. The hemodynamic monitoring, they emphasize that the previous guidelines was saying the target map should be between the 5th and 50th percentile for age. Also, they call it unable to issue that recommendation, but they raise it at the discussion of previous guidelines. The vasoactive medication, as we spoke of, and here they suggested the using of epinephrine instead of the dopamine in patient with the called with a cold shock and so on and so forth. The ventilation, there is no specific mode of ventilation to ventilate such patients according to the condition, and the use of corticosteroids, endocrine and metabolics. As we said, the same discussion we discussed, this is just the highlights of the summary. The nutrition and the blood product replacement, again, this is these two. The nutrition, as we know, that the good nutrition is very important in the prognosis and the outcome of critically sick patients as well. But this advanced step that will be taken care in the intensive care unit rather than the first hour in the emergency. Blood product replacement accordingly, and hemodynamic support as well. Plasma exchange, renal replacement therapy, and ECMO. Also, as advanced care should be taken over in the ICU within the next 24 hours of patient condition. The use of immunoglobulins. It is a weak recommendation, and according to the guidelines, and the prophylaxis. This is basically the summary. The algorithm they have been provided. They provided is within the first hour of initial recognition of septic shock, all of this should be done. The obtaining of the vascular access, collect blood culture, empirical therapy, and measure lactates, which has been already discussed thoroughly through the discussion. And the next is within the 3 hours of initial suspicion of sepsis. They said in the guidelines that if there is no septic shock, and no organ dysfunction, the antibiotic can be given within the 3 hours, but we are following the 1 hour guideline that our patient will come with ongoing sepsis. Here is the emphasis on the continuous reassessment of the patient and the need of fluid and active material titration accordingly. Okay. And this diagram also, sorry, this algorithm, again, speaking about the same problem list that we have been talking, a problem with fusion with and without hypotension. The first column is talking about the fluids and the titration of fluid accordingly. So this is a summary. Juniors, please screenshot this slide. By the end of the first hour, if you face a patient, by the end of the first hour, ensure that you gave your patient the fluid, the entropes, the antibiotics already all given, blood products as needed, dextrose of high glucose concentration of D10 plus or minus sodium bicarb if needed, according to the correction of the hypoglycemia and the metabolic acidosis the patient is in. Medications and electrolyte replacement that has been provided. Patient is already intubated and sedated. The tubes are secured. The EDT, the NGT, the urine catheter, the central line. The labs already withdrawn and seen, and monitoring timing has been set of complete blood count, renal function, the organ function of renal kidneys, VBG, lactate, ammonia, blood group, cross-matching, coagulation, cultures already has been sent and seen and reviewed, please. Imaging accordingly, X-ray after intubation is necessarily just X-ray. CT as indicated if your patient is having whatever needed of a CT. ICU bed is arranged and subspecialties needed are already called and discussed. Family updated and breaking bad news if the patient is crashing down in pulmonary sepsis. By the end of the first hour, make sure and ask yourself, have I done all of this, or I need to troubleshoot something else, or I need to do something more than that? Clear? Any questions so far?